As Joan mentioned, I would like to talk about how during the COVID pandemic, which has been across the world, how in India, how the COVID pandemic has impacted or played around on particularly the relationship between the public and the private sector in the market for healthcare, and what are the likely implications for the pandemic in the days moving ahead. So yeah, as you could see, I plan to talk on three broad heads. The first is I just give to for people who are I know there are a lot of friends and colleagues who are familiar with the Indian healthcare system and the market for healthcare, but for those who aren't, I'll just give a very brief overview of what are the key attributes and features of the healthcare market, and then I would proceed to talk about the recent behavioral patterns, the recent responses, and how the different market actors, chiefly the public and the private sector, has played out in the context of the pandemic, and how the relationships has emerged in the pandemic times. And finally, I would talk about, in the light of the evolving patterns, I'd like to talk of some likely questions and imperatives on what would likely emerge in or the road ahead, something like kind of trying to get a prognosis on the way ahead. As we all know, it's still very evolving, very fluid, dynamic, uncertain times. So a lot of it would be presumptions, but I hope to raise some of the questions that appears to be relevant. So as many of us know, like there's a map on the left which shows like India is it has been a cliche now that India is hardly a country; it's a continent in itself. As you could largely see that, those are the map shows the Indian provinces, and you could see that each province has a GDP. I mean, there could be many other ways of representing the diversity, but each province is representing a kind of a distinct economy in itself. So it's and along with comes the diversity and at the different ages of the spectrum of economy, society, culture, language, systems, politics. So it's actually a very highly diverse system that exists. Over the last 70 years, the Indian health system has come a long way, as many of us are aware. We have been able to successfully eradicate polio, contain the HIV epidemic, which at one point in the 90s were appearing to be a big threat and blowing as a full-blown epidemic in the country, was largely been contained. Several other communicable diseases has been under check. Fertility has been flying. India is gradually close to reaching the replacement level. Life expectancy has been on the rise, so it's increasing lifespan. There has been a lot of progress in increasing the coverage of a number of key interventions, key services, which includes, among others, like vaccination coverage, institutional deliveries, infant mortality, child mortality has been falling. So there are several bright spots in the way the health system has come across. India is a global leader in the manufacturing vaccines as we talk now. Several leading vaccine manufacturers in India are being approached, are being talked about regarding manufacture of the potential candidate vaccines for COVID. It has been a world leader of generic pharmaceuticals, across the world. There has been falling poverty. Again, rapid urbanization. Urban India is growing a lot, like close to a bit more than a third of India's population now lives in urban centers. Economic profiles has been changing, job roles. There has been a major shift from primary sector to more service sector led occupation, which is again very diverse. But uh, among all these, there has been persisting social and economic inequality in different dimensions, and there continues to be deprivation in access to several services, health being one of that, but also other services such as education, sanitation, and the other living standards like housing and transport. So uh, now the the several key inputs to the as trying to summarize the system as it is. Uh, the the key issue is the public. India is what we call as a plural health system. It is unlike countries in the Europe or in other parts of the world where there is a coexistence of the public and the private sector for long, and these what, as we say, like several the key inputs to the public health system continues to have several infrastructural constraints. Uh, and this relates to infrastructure, facilities, human resources, and as I say, like there has been a highly this the problem is one of low average, but more like the distribution of these key resources is highly skewed across the country, uh, and that actually leads to a kind of unbalanced, a kind of heterogeneous allocation of resources across the country. In terms of access to care, majority of Indians, like depending on it varies depending on which type of services you think about, but a majority opts for the private sector as their predominant source of care. But it's important to note that the private sector, unlike the Western world or in many other part of the world, is not always qualified uh, people with formal medical degrees and training, but as we call the informal providers. So a major part of the private sector, as I said, is remains poorly regulated and very highly diverse, ranges from super specialists to informal providers who lack any formal medical training. So which also causes that the quality and of the private physicians has also have a very skewed concentration. The private medical sector in India is very poorly regulated. We'll come to that in a bit. There is very little standardization of prices of different services, very little standardization of the treatment guidelines, the quality of treatment, the regimens being followed, and so on. So it's this kind of complicated diversity which remains. A salient feature of Indian health system is its abominably low level of public health spending. India is perhaps among the last country and no country of India's size spends so less of its public spending on health. So we have been sticking around this 1% mark for a long time now, and this being remaining largely unchanged at a time when the pre-COVID times, the GDP has been growing like one of the fastest growing economies in the world, and it's actually pathetic to realize that one of the fastest growing economies in the world has one of the least spenders on health, and that actually leads to a lot of the constraints the system faces. There is very limited coverage of prepaid insurance, unlike again the Western OECD countries. In India, very little, like less than 10%, or we don't have the exact numbers, but it's in low double digits. People are in formal sector employment. which makes social health insurance or employer-provided insurance insignificant. So there is very limited coverage of prepaid insurance. There is, I mean, some few in the last 10 years or so, several government insurance programs, like a kind of non-employment linked social insurance programs, has been introduced. Like there has been a program called Rashtriya Swasthya Bima Yojana, RSBY, and previously and since 2018, the PMJY, which is the sort of translates as a Prime Minister's health insurance program, which again, but these programs are, as I said, like these existing programs have a very narrow set of coverage. Like for example, the PMJY covers only hospitalized illnesses. Like you can only get coverage when you have a need for hospitalization, and also who are covered, like the extent, which is like it has a kind of means-based poverty, below poverty line kind of targeting program. So which is nowhere close either in spirit or intent to what we understand as universal coverage. So as a likely, most medical expenses are borne out of pocket, and like almost 75% of the health spending in India is private and largely borne out of pocket. And naturally, since that's some very, as we all know, is a very regressive form of financing, is a main cause of financial catastrophe and impoverishment. And there has been figures going like anywhere between 15% of Indians almost regularly fall into poverty because of these large expenses induced for medical care. And finally, in kind of describing the system, there we have been like India has a decentralized governance system from almost now close to 50 years, national provisions for decentralized governance, and within the health system, it's been again about 15 years now that we have systems for decentralized governance for health system involving the local actors. But that has been largely very sketchy and far from being an effective mechanism. We are yet to have a uniform national information system. Public health surveillance has been in a very archaic ways, which we have sadly realized during the pandemic, and thanks, as I will come later, some of it has definitely got a facelift during the pandemic, but it still remains in a very weak state, and which has largely led to unreliable and incomplete data, which naturally limits the extent of evidence-based policy. So with that kind of an introduction to the system, it's probably we can think, we can try to see what has been the kind of different responses of these public sector, private sector, and the other actors during the pandemic, to get a sense that how the market has actually been happening. The market, a big caveat is that a lot of what I will say here is based on reports in media and the interactions with colleagues. We are yet to have any hardcore data on how these have been played. Far from a survey, we are yet to have the concrete numbers. So, but I hope that most of it remains quite close to the reality.
Sumit, can I ask a question? I mean, like in principle, people can ask questions. I will pick up questions from the chat as well. Sure. Along the way. But just a quick question before you move into the question on COVID-19. I mean, why is it that the health system in India is so privatized? Is it because the medical profession is still quite weak? Is it that health policy, the healthcare sector is not really pinpoint as relevant from an electoral perspective?
Yeah.
Why is it that it's so small? Because it is small even compared to like really low-income countries?
Yeah, I mean, it's very natural. There can be a long answer, but the short answer is it's natural. Like health care there has not been any hardcore, any very strong regulation which prevented the entry of private sector in providing healthcare. That has been one reason that there has been an absence of strict regulation. Like, for example, you 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 prevent a private sector from working on health service provision. And the other reason is India is too big a country. And the public, as I said, like the public spending has been inadequate, which had kind of left those gaps in provision. So the kind of offering of publics, although I mean there are sub-center clinics, small health clinics in almost every Indian village, every settlement, but services are either not available or of poor quality, or infrastructure is not available, which means that on the one hand there is lack of adequate regulation which prevents entry of the private sector, and on the other hand its public sector is inadequate in its offering. So there leaves a lot of gaps in the services being offered commensurate to the demand. So the private sector thrives, and it thrives in a big way.
And following from that, what is the role of traditional healthcare? Is there like in other countries like China, where there is actually an alternative sort of medicine sort of model there that could compete with modern medicine, or that's more negligible?
No, that has been, I mean, that had been a kind of the traditional, what we call as the Indian system of medicine, like the Chinese medicine. The Indian system medicine is a very age-old tradition, and that is still there, but both in terms of its coverage as well as professionals available and the services, it's not a major share. So it's still the modern, which you call as allopathic medicine. So the modern medicine is still the predominant form, and traditional medicine remains, but as a very largely insignificant part, either in terms of services provided or populations covered. Yeah.
I don't see any other questions in the chat, so go ahead.
Okay, thank you very much. So the kind of, so India, as I said, like in the coronavirus epidemic, India has been one of the leading global hotspots. Like as of yesterday, there was about more than 9 million cases, although about 8 million of them has recovered already. But there has been about more than 130,000 deaths across the country, which again, like, seems very high, but given the size of population, it's not very high in absolute terms as well. And there has been several phases of lockdown. Like India has, as it goes, is probably one of the first countries to go for a national lockdown in the middle of March, towards the end of March. And one can easily imagine of a country of India's breadth and scale and diversity and the kind of structure. It's a humongous. Nobody ever believed that India could be ever put in a lockdown for such a long time. But there has been several phases in different regions, ranging from a few weeks, like 8-10 weeks, to more than 12-14 weeks in several parts of the country. And naturally that has caused a restricted mobility, and economic activity for major part of India has grinded to a halt, or being kind of largely affected in some way or the other with this unprecedented shock. And mind you, India, because of the informal nature of the labor market, and there is nothing which in this part of the world people talk about furloughs and economic retrenchment and safeguarding of jobs. It was nothing like that. So the lockdowns effectively means that if somebody couldn't go for work. There was no wage. So that was a major, like, in a way, not just a macroeconomic shock, but very micro level. The lockdown and the pandemic had impacted very micro level livelihood shock to most Indians. And naturally, there has been a forced kind of downward adjustment in the demand for care. So there was, on the one hand, there was lower ability to pay. People didn't have enough money to spend for healthcare, but at the same time, lockdown also meant like the supply of health care also was affected, especially in the private sector. So there were clinics were closed, physicians were not attending to people. I mean, private physicians. So there was a kind of an action in both ways. Now, it's although now over the last couple of months the lockdowns has been gradually lifted and things are gradually crawling back to normal, but the kind of ripple effects of the lower demand, of the reduced demand, continues, as well as things like social distancing protocols in health facilities and kind of safety concerns for non-emergency care. So it's not unheard of that people have postponed their either forced or chose to kind of postpone their non-emergency medical care, which kind of is going a kind of a more structural adjustment on within the market, which is likely to modify in the days ahead several aspects in the way such a marketized system kind of functions. Now, a very interesting development which many colleagues in India has noted and has been written is the pandemic has also seen a kind of emergence of a different, a kind of an assertive and radical looking public sector, because one reason was simply that private hospitals and clinics have shut shop and run away. But so during the pandemic, the public sector has been the dominant, if not the only healthcare provider for large parts of India. And if you think that before pandemic, almost 2/3 of the care was being accounted by the private sector, this means a kind of massive shift in the way the market operates. So a kind of in principle, a kind of forced nationalization of the health system, which is remarkable. There has been very different radical measures, like Epidemic Diseases Act was imposed, which made private hospitals to compulsorily address to COVID patients wherever they're open. There was a huge extent of requisitioning private beds by the government. A lot of private hospitals were converted to COVID hospitals. Many still remain. So a kind of a tectonic shift in a way the public sector operated. On the other hand, there has been also kind of expansion of diagnostic capacities like COVID testing, and a lot of media reports say in India we are being testing quite less, but at the same time, there has been records and of district hospitals. I know a few of them myself, where in early days, even in early days of the pandemic, high-end testing equipment and setup were established in a lot of district hospitals, primarily in the high burden areas. An important fact has been, although it has been said now in a bit, but the kind of game changer role of the frontline public health workers in India. And mind you, like in India, these frontline health workers, a lot of them are not even paid, so they get a paltry honorarium. So these people who get paid very less, and naturally, a lot of us believe that the motivation levels might be quite low, but these frontline public health workers had done an exemplary work across the country, like from screening and testing and isolating and taking patients. One can go on and on, but there's been a very different role, a very active role of these frontline public health workers. But at the same time, it is useful to note that COVID being a largely secondary and tertiary care oriented disease, at least when it gets serious. But the use of the hospital insurance program in India, PMJY, for COVID treatment has been insignificant. Like I don't have the exact numbers, but I was there were reports in June which said that it was very paltry even when comparison to the number of cases. So which means like government insurance was probably not been a lot wet. So a question to wonder that whether the kind of a visible hand to make the markets work in the way which it perhaps should be and beyond. A worrying sign is like primary care in the pandemic phase probably could have been relegated into the neglect because of one is this adverse opportunity cost. Like a lot of routine public health programs, like you can go from immunization to pregnancy screening, to the TB control program, leprosy, malaria, HIV/AIDS. So a lot of public health programs which actually relies on the frontline health workers and the public system, which I was mentioning, which has been stretched to its extremities. So naturally, these services were foregone, and there have been some numbers going on which says like, a lot of setback, which could perhaps also reverse some of the remarkable gains in some of these programs. And the kind of the philosophy of being a kind of being over kind of sort of preoccupied with the number of hospital beds and ventilators, oxygen facilities, and so on, which is a kind of secondary tertiary sector orientation, would probably also risk a kind of further neglect of the primary healthcare. Like one can, for example, the talk in India has been at the same time of the hospital insurance program. There has been also a national program on revitalizing the primary health centers across India, which were being called as health and wellness centers. But over the last year, like during the pandemic, nowhere it has been not seen or heard. But which is important to note that a major cause of death due to coronavirus in India has been what they call as comorbidities, which are ranging from respiratory problems to diabetes and hypertension, kidney problems. Now, a lot of these NCDs, as we all know, are effectively managed longer term in a primary care setup. So, ignoring this primary care or a kind of neglect of primary care could actually be counterproductive in the longer run. So, and of course, there is a chance of, because of private sector being the formal private sector, the qualified private physicians, clinic, and hospitals being largely out of bounds, there could be a risk of even a higher reliance on informal sources of care. Now, when we see this assertive public sector role and a kind of realignment, the private sector responses has been quite a mix. On the one hand, there, as I've been saying, like there has been a lot of reduced operation, so a vacuum in the market, so falling supply, but and importantly, like a number of private, and I think this is a very, very significant point, that much of the private sector in India, as I've been saying, which is very highly heterogeneous, but a significant part of the private hospital sector are what we call as the small and medium-sized hospitals. They go as various names: nursing homes, polyclinics in India, like ranging between anywhere 10 to 100 beds. Now, many of these small hospitals have been facing a severe liquidity crisis during the pandemic, and a lot of their operational viability is being at risk. Now, these smaller hospitals, at least in the non-metro areas, and in semi-urban, peri-urban areas, these smaller private hospitals are actually the backbone of organized private sector. Now, if these hospitals are not economically viable and they are, something happens on their on their viability, which can cause major instability and supply side imbalance in the short run. At the same time, as a lot of media reports has been going, like, in a less regulated market, as we call as Shylocks, we remember the Merchant of Venice in Shakespearean play, which we extract the pound of flesh. So even several reputed big franchisee hospitals, there has been reports of excessively charging patients for COVID treatment, like mind-boggling sums, and even a lot of excesses. In many states, they've gone to medical litigations even. So, on one hand, this kind of unscrupulous opportunism has also being seen, and in many states, the governments have to, issue ordinances and several measures to kind of prevent hospitals to stop charging excessively and give a predetermined schedule of charges. But again, like, that all remains how monitored they are. So there has been this kind of problems and exigencies there.
Sumit, one question. We have one question in the chat,
Sure.
which is asking if you think COVID-19 will refresh the regulatory norms in the private sector during COVID times. Because the question says, while COVID-19 undoubtedly made the inadequacy of COVID of health provision in India apparent, do you think it will refresh the regulatory norms in the private sector?
Yeah, I'm coming to that. Of course, yes, they're like, naturally it seems like some opportunity for regulatory reforms remains, and I'm just coming to that. So please bear with me. I'll be talking this in this section, and this is my final section. I'll be highlighting them. Probably if the questions remain, I can answer. But yes, I'll be touching upon them now. So based on the structural features of the system and the way, as we briefly discussed, the way the roles of private and public sector has kind of shaped up during the pandemic. So probably we can take a look at some of the new, and I make a note in small, like old questions as well, for what the post-pandemic health system might be. And these are all like kind of sort of informed guesses. We don't know yet how or in which way these will effectively realize, but can be reasonably hoped that most of it would be still holding true. The first is, starting on a bit pessimist note, that there is big risks of new perverse incentives and market failures. So lot has been written on the Indian health system, and a lot of colleagues, including us, have commented and written, analyzed a lot on how in a sort of highly marketized health system as in India, perverse incentives and market failures are quite natural. Now, there is a risk of these getting intensified and a lot of new risks emerging. First is, an ominous sign is, as I said, if many of the small hospitals and medium hospitals, which lend a sort of competitive nature to the private healthcare market, now if these lose economic viability, and there is already indications like many big chains, like I can give name, Apollo, Max, and all the major players, the large scale players in the tertiary care sector, if they go for an acquiring or kind of acquiring many of these smaller units, which can actually reduce the competitive nature of the market and lead to kind of anti-competition, as we say, a kind of reducing the competitive nature and kind of concentration of oligopolistic power, which could be very detrimental to the way the organized sector works and can lead to several perverse forms. Another kind of worrying sign, which is already evident, is a kind of inflationary pressure from private insurers and hospitals. Now, on the one hand, for the few, Indians, mainly urban middle class, upper middle class Indians who have resorted to private insurance already. And there has been reportedly, I've been talking to some of my friends and colleagues, and already few of them say that. And for the friends in India, probably they can say it more, like already the Mediclaim people has been asking them to kind of upward revise the sort of sum assured and like kind of the amount of coverage, because there's been saying like most private hospitals are likely to revise their charges upwards. So like if, for example, previously you have a cover of like X rupees, and now there it probably would, to get the same amount of services, you would likely to need a cover of X plus Y, which means higher premium. So that's the kind of more individual kind of inflationary pressure. But also like many of the when where the government acts as a purchaser, like programs such as the ESIC, like the sort of the insurance programs for government workers and civil servants and blue collar industrial workers, like the central government HS health scheme or things like that. Now, a lot of the private hospitals are trying to pressurize the government for, increasing the rate contracts. So the rate at which services has been agreed for being purchased by, uh, these agencies, there has been already a kind of pressure to kind of increase these in an upward way, just on the pretext like, charges have increased because of social distancing, PPE, and all of that. So that kind of inflationary pressure can actually create a lot of inefficiency and perverse nature. I mean, the other thing which we have been not talking about as much as we should, but the access to COVID vaccines could be Pandora's box. Like in a highly marketized system, it doesn't take a lot to imagine that, apart from starting some kind of a price war, even if it is not regulated and people can try to jump overboard for getting access to these vaccines, and but also this kind of could create a kind of perverse impulses to other linked markets such as drugs and diagnostics. Now the important question here is, as I've been saying, like the public sector assuming a new assertive role. Now, can the public sector counteract and consolidate the new challenges? And if so, what it might entail and at what cost? The answer to me is a convincing yes. Is a resounding yes, that definitely the government should come forward and counteract and actually maintain and in fact strengthen the assertive stewardship role that it has been showing during the time of pandemic. And although a lot could be said about how the government responses could have been better, but no denying the fact that for a country of India's health system, as I've been saying, the pandemic could have been much, much worse had it not been for the public sector. So no denying the fact that it can actually maintain the assertive role and in fact channelize it to the right directions, which many of us have been saying for quite long, in a planned, futuristic manner. Like as our colleague was asking, like the question of regulation, yes. Some of the strategies could be, for example, it could give a kind of credit support, fiscal support to the small and medium scale hospitals and engage in some kind of contract there. This remains a major sector which could be tapped in a way where instead of we talk of strategic purchasing, but purchasing could be in a very very different form by the way in which the government can rapidly expand its capacities by kind of, I'm not talking of acquiring them or kind of nationalizing these hospitals, but sort of thinking of in some way, and there are options in how you could reach out to these hospitals. Freezing rate contracts, I think that is absolutely important, that to check all these adverse inflationary tendencies, all rate contracts with different social health insurance purchasing should be freezed. But at the same time, in order to take care of the relevant, the necessary fiscal considerations, there could be fiscal stimulus packages available to the hospitals as well, which we have not yet talked of. Yes, as our colleague was mentioning about regulatory norms, I think we must seize the opportunity for a medical prices standardization legislation, which definitely is order of the. We have been already trying to do something with stents or some other medical devices in the pre-pandemic times. The vaccine also is something where the government seems to be talking about some kind of price standardization and ceilings, but it's high time we need to do it on a wider part of the board. So kind of broad spectrum price standardization is a first step to regulate the market, but we definitely with quality accreditations, because if the quality varies largely according to type of services, there should be some premium. And already, like, I don't want to go into much of that, but the PMJY has already started to allow different rates for different category of hospitals based on their quality accreditations. We could think of something of that on the non-hospitalized segment as well. Drawing from the fact that the health workers has been a phenomenal role during the pandemic, we need to think of expansion and skilling programs of the frontline workers, which sort of ambitiously called as a national human resource for health mission. So is definitely a way in which this consolidation should go on. There has been questions raised, like in a very recent paper in IJM and a recent policy paper in the Indian Journal of Medical Research, Professor Indrani Gupta and Rama Baru had raised several questions on how efficient, equitable access to COVID vaccines in India could go about. We are yet to have a clarity on, even today, as we have been talking, like the Prime Minister is having a conference, or just had conference with the chief ministers of the key states to talk of how the access to COVID vaccines could be streamlined. And this remains major. One thing which I'd like to mention, that India, we are thinking of market-based channels for distributing vaccines, but India has a record, very, over the last decade and a half, on several aspects of health system, of health service delivery. The not-for-profit voluntary, the SHGs in India, has come in a big way and played a major role in several healthcare programs. And there is no reason why some of them, or a few of them, could be tapped on to kind of act as the delivery platform, the kind of mechanism for distribution of vaccines in a more community-based, sensitive way. So I would like to think of these as one key option. There is no denying the fact. Yes.
One. We have a number of questions now. Perhaps it would make sense to deal with them now, because they are mostly on regulation. Okay. So we have a question from Marka Hellowell, who asks, could I ask Sumit if government has responded to the liquidity problems in the private sector? Is the state, and if so, is the state thinking of providing subsidies, and if so, to whom? So that's one question. So liquidity problems that might arise as a result of COVID-19, and whether there is any, you can let us know whether there is anything along the lines of subsidies that could be provided. So if there are any providers considered systematically important through enough to warrant government support. So that's one question. Then Udaya Mishra has posed another question. Can such regulation involve making private sector cater to underserved regions, because it is not infrastructure alone, but human resource for health, which is more unequal? So one question on regions that are underserved, mainly because of human resources. The question on subsidies, and then make that as ask a question, do you think that there is a role for India to re-emerge as a pharmacy of the poor, as in the HIV global epidemic? So lots of questions for you. Just feel free to pick up the one that you feel more comfortable to start responding to them.
Yeah, I probably I'll be ending in another couple of slides. So when I can see the questions, maybe I'll respond more, but I will take these questions anyway. I'm almost towards the end of what I want to say. But the first thing is, I'm not yet aware of the government already thinking of the kind of liquidity problem and subsidies. There has been sort of indirect monetary policies to kind of make more credit available to the banks. But as far as I'm aware, I don't know. I'm not yet. Maybe some of our colleagues in India will have some more answer, and if I can get later, I can let know. But I'm not aware of any such steps which the government has taken explicitly to address the liquidity crisis or the liquidity problem for the private sector. So, but I mean, I just mentioned without probably thinking of that as a potential step that might be considered. And I hope probably the finance minister or some of the policies it must be lying somewhere. But yeah, so not yet already, but as far as I know, but I can be wrong, but definitely worth considering. Regarding to Dr. Mishra's question, yes, and I think definitely the kind of there are several opportunities, right? Like when I say to kind of if the kind of the vacuum that has been previously, as I said in the start, the private sector had actually emerged in many ways to account for the gaps that has been left by public sector to address the unmet need. Now, if the private sector itself in some way is reluctant or unable to respond, there is definitely a way for the public sector to, and that's what stewardship is about, right? To kind of make use and in one way, this and the talk of the subsidies or talk of the liquidity support could be conditional, right? We can think of making this conditional and use the kind of nudges, kind of leveraging these ways in which we can take care. I mean, one can think of options where you can ask, like for example, where there has been talk of in old days, like in India, where banking sector, where the financial sector hasn't gone to remote parts, the banks were given the charge of adopting districts and developing the banking system there, and take, like, one can might be a bit radical, but one can think of in ways in which we could, in lieu of the credit support, in lieu of subsidies, in lieu of helping the private sector off, so kind of that in a way you can ask, or you can make them to kind of cater to those underserved regions. So there could be ways in which one can think of a little different public-private partnership than what has been peddled around. As Migdad said, like Migdad knows very well, yes, we have been talking definitely. India has played a major role as a pharmacy for the poor, for the poor world, and its role for the generic market, and actually for the HIV/AIDS, the antiretroviral drugs has been remarkable. So definitely, and I think a very interesting part is the global supply chains has changed and is also likely to change even further, and this includes even the pharmaceutical supply chains. So, like, very simple way, like paracetamol, which is a very common antipyretic drug. Although India is a world leader in generics, but China actually manufactures the most number of paracetamol products, and it goes for a number of other antibiotics as well. So, and these like kind of bulk drug purchasing and manufacturing capacities has sort of, I don't have my grips exactly on the numbers, but some of those public sector drug manufacturing units, like we have friend which comes from, like, the part in India where I come from, West Bengal Chemicals has been a major public sector pharmaceutical manufacturer, and providing low cost drugs, bulk drugs, and which has kind of withered away and suffered a major setback. It is only now that they have been given orders to kind of provide to manufacture sanitizers and kind of disinfectant liquids. So there is no reason why several of these dormant public sector, semi-public sector undertaking units across India manufacturing pharmaceuticals couldn't be revived. So probably the vaccine and the other manufacturing could give a fillip to the dormant public sector market in India for pharma, and also the unspent capacities in the private pharmaceutical production market. I'm not very familiar with the TRIPS and the IPR regime in pharma products, and these days a lot of contract manufacturing in pharma is being taking place. But I think a lot of that will witness change because of the pandemic and the revisit to the global supply chain. So yes, that could be in order. And just kind of last two slides before I end. So the thing is, none of these which I've been saying is possible without a transformative increase in public investment in health. I call it a bit now more than ever. It's not that, we all know it's a kind of economic contraction. India is probably, as technical terms, is on the grips of recession or almost looking at it. And there is a tendency world over to even go for more austerity when in times of recession. But history has proven it otherwise, like that to be counterproductive. And so at this kind of what goes as this fashionable new normal, the response is not of contracting public spending, but actually expanding it. And we need to kind of move away from the notions of those restrictive budgetary management which people has been prophesizing to pegging to budgetary deficit, keeping them to a threshold. I think it's time to move away from it. And there has been several brilliant brains in economics which has been talking about in a way public spending should reposition itself in the post-pandemic world. And I don't want to go into that, but it's, I think, to walk away from that. I've been giving a lot of examples in a way. Expand the health system capacities need to be expanded, and among others it also includes kind of investing in the health information system, because in no way you talk of regulation, you talk of monitoring, you talk of stewardship, you talk of evidence base is not possible without a strong health in information architecture. We have realized it in a bad way when the pandemic came, and we are still kind of we're not having the kind of analysis which friends in the UK and other places could do of the kind of socio-economic character of the pandemic. We are unable to do it in India yet, just because our information system lacks the capacity. And it's a joke, because when India calls itself as an IT superpower, it's to not have a health information architecture is. But thankfully, as far as I know, and again people will know better, that a lot of initiatives have been initiated to develop the kind of patient information architecture, a health information architecture across India. We need to take that to the next level. My final slide, and I would like to end in that note, is the critical game changer role here is political will and governance. Across the world and within India as well, there has been numerous examples like successful responses to COVID has a common thread, that of good governance, that of effective political decentralization, and strong political will and leadership. So we really need to kind of to stress on that, and we cannot be emphasized enough. We need to develop merit-based institutional capacities at local levels. It has been proved time and again, and the pandemic has probably highlighted it in the strongest way, that decentralized and coordinated responses are at the core of success, core of effective responses. So, and with the rich democratic traditions in the country, India is the world's largest democracy, and we have been holding elections even in the time of pandemic. Large number of people turning out and giving a strong mandate. So we need to leverage the strength of democratic political institutions, and that is by improving accountability in several ways. Again, one can talk a separate seminar on this, but the need of strong social contracts in the way in which the state builds its legitimacy. It's already like, in a way, the pandemic has kind of rekindled the people in India, as in many other parts of the world, has been looking up to the state again for direction, for guidance, for help, for steering through. And I think that aspect of social contract between the state and citizens needs to be built upon. Health policy reforms is inherently political, will continue to be it. So the way in which we capitalize on the political will, have exemplary good governance, think of progressive ways in which we can build on the market and form the real partnerships, not in the sake of name, but in purpose, and support it with sustained public expenditure on health. That could be the way in which probably we can hope to look in the uncertain days as we emerge out of the pandemic. Thank you very much. I like to stop there and see the questions, and here is my email and my tweet for if you have any comments or questions even beyond the seminar. Yeah.
Thank you very much, Sumit. That was an excellent presentation. I think we got like a very clear perspective of what COVID-19 entails for India, and I see that we have a number of questions there. Maybe those of you who have posted questions, I see Catherine Goodman having asked a question. You suggest consolidation is a risk, but do you think that there are some risks in what is currently a very fragmented S&M health facility sector? Would greater consolidation facilitate quality improvement? So a question for you on consolidation, health S&M facility sector. So perhaps we could start with that one.
Yeah, so I'm trying to see the question. So Chinmay Mitra is asking like how the considering subsidy to the who become sick. Yes, I think I mentioned that if that is your question on whether we need to think of subsidizing the small scale hospitals and nursing homes, that has been one thing which I've been saying, like opening up lines of credit for these hospitals to make them economically viable. And this has been a worldwide phenomenon, like smaller private sector units are actually the ones which has been suffering in the market. So yes, definitely need to think of their interest and accounting for them in the best ways possible. So sorry, my laptop is about to die out. Yeah. So
so we have a number of questions. I think you've gone through the last one.
Yeah.
But there are a few more before. I mean, there is one on consolidation of the health facility sector.
Yes.
In India.
Catherine Goodman.
Exactly.
Yeah. You think some risks in which, and that is currently very fragmented, would greater consolidation facilitate? Unlikely to be so. Unlikely to be so, Catherine, because it's not that quality isn't just a factor associated with a brand, and it has been seen that it's largely related to several resources at disposal, and depending on the way in the area in which the smaller hospital which is being consolidated, which has been acquired, remains. So I mean, of course, that could be a way in which in a small way, yes, consolidation could actually lead in principle to some kind of improvement in quality, but the costs of it, the risks of it probably outweighs the benefit. It could actually start a little, like for example, the price premium that can go with the kind of sort of notional quality improvement could actually be far more. So for example, if you think of something as something like an angioplasty or something like that, an invasive procedure in a metro big name large franchise hospital and in a smaller unit which has been acquired, the quality is unlikely to be at the same level. But if the price, so hiking up the price is a very undesirable way of signaling quality improvement, which is not always the case. So I'd like to think that with some caution. Yeah. So
then we have 2 more questions. Do you see any hope for any change to promote health as a whole and universal health coverage in the political agenda in India post-pandemic? And do you think that the pandemic could it be that the pandemic becomes a tipping point so that health becomes more salient in the political agenda? Do you see any hope for that?
I'd like to imagine, yes, because if health is not back in a political agenda, or health is not the prime political agenda after the pandemic, then I doubt it ever will. So and I think it's natural that probably what the pandemic has highlighted bold is that universal coverage, what it actually means, how preventing people to fall down, how having systems as a resilient things that we have been talking, like the health system and the health system research community has been, health policy community has been talking for decades, is probably straight on our face that yes. And I think if this does not brings or makes health policy in its place in the universal healthcare agenda, I don't think it ever will. But but as I said, it depends on the way the political system is arranged. So I don't know. I mean, in India there was a provincial election fought just after last couple of weeks back. I'm not fully aware of how, so probably my ignorance helps that, but there in some way, even in indirect way, like for example, maybe may not be the direct talk of the pandemic, but some way, and one political party which incidentally emerged as the victorious one has promised in its manifesto of free provision of COVID vaccines to people in the state. So I mean, could be not a very good example, but yes, I think in some way health was never there even in the political agenda, but even for more sellable components like access to vaccines, it could come up and it could kind of make that. But yes, I would hope that definitely there will be realignments, definitely changes in which it take place. So yes, why not? Maybe that's the challenge for the political system collectively ahead. So,
and then we have some questions more on the politics as well. So one is a more general question about what pro-equity policy actions could be thought of in the context of India. Another one about how to encourage basically the public sector in India. I mean, basically saying that the public sector is still very weak. How to make it stronger by Amir Sohail. And I had some questions as well in terms of, I mean, you mentioned democracy as a way to strengthen the public sector. I mean, one of the issues there is our resources as well. So, having democracy alone in a setting where still the informal sector is quite strong and people might not necessarily be willing to contribute to paying more taxes, because ultimately to strengthen the size of the public sector, you need probably more resources, more fiscal revenues to go into the public sector. And of course that will require some form of fiscal consolidation of some kind in the context of India, and normalizing basically people's contribution to the public purse, right? So normalizing paying taxes and reducing the size of the informal sector. So it looks like all these reforms that the health system desperately needs require a wider macro structural reform. It's probably not going to be enough to just make adjustments to the health sector to allow all these changes to happen. So we have 2 or 3 questions more along the lines of what to do more with the public sector, how to strengthen the public sector. So
I think I'll start with your question. I'll start with a kind of a shorter response to what was a very a good question, and on which you asked. I think India is one of the countries where the tax GDP ratio is very low, and I think a primary reason is the tax structure in India is such that direct taxes, which are the more progressive ones, as we know, is still fairly low, very, very low in the overall tax envelope with the government collects, the revenue envelope. It's still largely indirect taxes, which again is very regressive. So, but the answer is, expanding direct tax base is already politically more tenuous. So it's, but I think in some way, yes, I think expanding or strengthening public sector capacities or public sector presence goes hand in hand with the fiscal space, which again is threatened during the pandemic. But I think the kind of fiscal consolidation and building on that is a bit longer term agenda, which one needs to walk with caution. And but it definitely is a question which we can't ignore, and we need to confront. And hopefully governments would have the courage in some point sooner rather than later to kind of start taxing, like for example agricultural sector in India, and there are quite a few big agricultural so-called the rich farmers in India, but they don't pay any income tax. So it's a politically challenging question, because they are the backbone of most political parties. So, but in some or other, they need to be brought under the envelope sometime. But I think on a more immediate time, I think there are other ways in which through more monetary policy, I would like to feel that a lot of the immediate expansion, the immediate kind of infusion has to be on the route from a monetary policy. And I think there has been ways in which people has been suggesting, and there are, I'm not a macroeconomist, but there are macroeconomics friends in India who have been coming up with ways in which the monetary policy response should be to kind of back the public sector strengthening role, not just in health, but in other areas. So yeah, I would say fiscal consolidation, definitely progressive reforms on taxes is a long due agenda. We need to do that, but of course, immediately I think it's more through probably the monetary policy route. There was this question on pro-equity, policy actions. I've been mentioning quite a few, right? Strengthening the capacities of frontline health workers will actually improve the public service delivery in the far-flung areas and areas which are remote. So kind of acting to that will be a kind of more equity. So in service delivery, the other way in which equity in service delivery would be in kind of, as I said, like capitalizing on this kind of capacity available at the small medium sector hospitals in smaller or urban semi-urban areas, which could again be some kind of pro-equity. Reducing the inequity in access or inequity in service delivery. As far as inequity in financing goes, there is no new answer, I would say, because we have been talking a lot on how the kind of fragmented financing option, which under a health insurance program like PMJY is unlikely to transform or to kind of do a significant impact on reducing inequity in financing, and our past experience is not that. But so probably we need to make it in better way in which and so this is not just with COVID, and something which has been influenced under COVID, and has been a kind of an agenda that has been there for some time now, that until and unless financial risk protection is extended for more routine, more common, like more outpatient, non-hospitalized illnesses, regular illnesses, it's unlikely to have an impact on inequity in financing. So it should be thought in its totality in that way. Am I missing something?
No, I mean there's some questions, but they are more okay. There's a question about some slide, whether you will share the slides, and the answer is yes. And there's a final question before we actually draw the seminar to a close, which is, what do you think could be a starting point to start addressing health inequality issues, which is something that you've already touched upon, but do you want to say a final word on this before we call it a day?
I think thanks, Oshima, for the question. And I think it's as I've been saying, it has to be through, the first starting point should be a strong public sector role. You cannot leave healthcare to uncontrolled market forces, uncontrolled, unregulated, unplanned private sector dominance, and hope that in some way, the invisible hand will ensure equilibrium across all. Like the Health Economics 101, Health Policy 101 teaches us it is never going to be the case. There will be abundant market failures, and health inequality will go hand in hand. So the first way would be a strong, assertive role of the public sector, which starts with something. And as I know, like many of our friends we have been crying hoarse of the demand of at least a threefold increase to the public spending as a proportion of GDP. So as spend more, spend better, so more money for health, a strong public sector, an assertive role, and right stewardship with political will. It goes more like, it sounds like a more tall talk, political prophesizing, but can't help, like the basics remains the same, and unfortunately it hasn't changed much even in the pandemic. So strong role for the public sector, reducing market failures and cashing on the opportunities that the pandemic has brought to the public sector should be a way in which we can steer the market towards a better, and as we say, make the markets work for the poor.